on modeling to support policy lessons from the pandemic. Thank you very much.
Thank you. Thanks very much for the opportunity to speak today. The last time I gave an in-person talk was actually February 2020 at the Fields Institute, where we were talking about whether or not there was going to be a pandemic. So it seems pretty fitting for for this talk to be happening at the Fields again. We're talking about lessons learned from modeling during the pandemic. Before I get into the sort of subject matter of the talk, I really wanted to anchor this in sort of two things. One, recognizing that, we're talking about lessons learned, but the pandemic isn't over. And the other thing I really wanted to emphasize is that I think as modelers and people who work with data, we're dealing with numbers all the time. And I think sometimes we lose perspective, or at least I sometimes do, when we hear about greater than 45,000 Canadian deaths. At this point, more than 6.5 million people globally have died of COVID. And so I just wanted to take a moment to acknowledge that and recognize the fact that, as much as this is, an intellectually, potentially interesting topic to be talking about, it's also one that has really important real world repercussions. And I always try to keep in mind the fact that, we are really, doing, I think, the work that we do is ultimately to try and save lives and protect the health of people. So what I was hoping to cover today was really, it's not going to be a super technical talk. It's a little bit more reflective in terms of, how we use models to support public health decision making, how we build policy models, and how does the process of building these sorts of models actually sometimes involve decisions that may have implications in terms of the outcomes that we model. And also wanted to talk a little bit about communicating policy models. And for those of you who were here for the career panel this morning, this is actually, I think, fits really well with what we were discussing this morning in terms of, there's this technical side of being a mathematical modeler or an epidemiologist, but there's also that translational piece. And I think that one of, for me at least, the major lessons of the pandemic has been that translational piece. How do we communicate the work that we're doing, and how do we do it in a way that both maintains our scientific integrity, but also gets across the important messages that we need to convey? So I'm talking to people who are mathematical modelers, so you probably have a very specific idea of what a model is. I may present you with some points, and you can come up with a model to describe the process that is generating those data points. I may show it to somebody else, and they'll come up with a different model, and that may be the third person's model. Essentially, models are simplified representations of reality, and we use them to explain the world around us. And the reality is that everybody is a modeler. So, when I tell somebody that I do mathematical modeling, the reaction is usually, oh, wow, you must have been really good at math in high school. And it's not that. Everybody uses models to navigate the world. And so I think one of the things that as modelers we can do is to sort of take that step back and sort of recognize that people are using models all the time, and that math models are just, a segment of models that we might use. But they're not scary or intimidating or black box. They're just another way for us to understand the world around us. So how do we use models? This is some examples of how we might use models, and these are all drawn from the pandemic. I think the most prominent use for models has been for forecasting, so trying to understand what's going to happen in the next couple weeks or the next couple months. It's been used for scenario planning, so trying to understand, if we take certain policy actions, how might that impact what we see in either, again, the near term or the longer term future. Making inferences about unobserved data. So this was really important early on in the pandemic when we were trying to understand, the basic characteristics of the SARS-CoV virus and how it was transmitting, questions around asymptomatic spread. Modeling was really important in all of that. characterizing infection dynamics, which I guess sort of ties in with that, making inferences about unobserved data, and then understanding and or guiding policy. And I think, you know, these are not necessarily, this is both a non-exclusive list and also probably a non-mutually exclusive list. So models can serve different purposes at the same time. So why do we do modeling to support public health decision-making? I think this is something that I've thought a lot about because I think modeling during the pandemic has been both very interesting, but also really challenging. And I think the challenge relates to the fact that the communication of models has been challenging and the response to models has been challenging. And so there's this question of, you know, is this valuable? How is this adding to the body of work that we use to make decisions? And so, you know, ultimately, I think everyone would recognize that choices must be made. When we make choices, we're weighing the costs and benefits of different options. And when we take one option, we forego the benefits of other options that we might have taken. And so mathematical modeling can provide a mechanism for essentially laying out those assumptions, our current knowledge and our values, and making them clear. And so I think the thing that's nice about models is that they really force us to be explicit. So, you know, you may be making a decision based on, you know, your gut or based on, you know, what you think is going to happen, but oftentimes we're not explicit about what those assumptions are that go into our judgment. And so models can provide a way to really make that clear about, you know, what we know, what we don't know, and how that influences what we perceive as the optimal choice. So on that previous slide, I said in values. And so you might say, what do values have to do with public health modeling? And this is a quote from an article that was just published by someone named Greg Gonzalez in the United States, who is an epidemiologist. And he wrote, you know, we've heard again and again over the course of this pandemic that public health shouldn't be political. But this is a fundamental understanding of public health, which is not just a technical discipline offering data and decision-making frameworks, but carries with it a commitment to addressing the needs of those most in need, the most vulnerable, the most at risk. And I think that, you know, people go into this field for different reasons, but I would say probably very few people go into public health because they're planning to have a super lucrative career where they're making tons of money. I think the reason that we're drawn to this field is because we want to make a difference. And again, this may be a generalization, but I'd say in general, you know, we're here because we want to help people. And so inherently there are values there. You know, we're doing this work because we think that human life is valuable and that we want to improve population health. And so values do play into public health modeling, and they can play into public health models in different ways. We're making choices all the time when we build a model. We're making choices, and some of those choices involve value judgments. So for example, the population that we're modeling. Who are we including? Who are we excluding from a model, and why? The model time horizon. Are we looking at the very near term? Are we looking further into the future? And are we considering both the short and long-term impacts of a potential policy option? You know, would choosing a different time horizon change our conclusions? In terms of interventions and outcomes, are we excluding certain interventions? And if we are, is there a reason for that? And what is that reason? What outcomes have we identified important? So what are we actually measuring? And why have we chosen that outcome and not another outcome? And would choosing a different outcome change our conclusions? So I want to dig a little bit deeper into each of those aspects in terms of choices with modeling. So the first is this model population. So it's become very clear throughout the pandemic that capturing population heterogeneity really matters in terms of capturing and understanding inequities in infection risk, in risk of severe outcomes following infection, and the impacts of public health interventions, be they positive or negative. And so I just have a few examples here of this sort of differential impact of the pandemic on different population groups. So here we go. This is looking at the mortality risk at the very, very early stages of the pandemic in residents of long-term care homes versus non-long-term care home residents. And you can see, we saw very early on this very, very disparate risk in mortality amongst long-term care home residents. Similarly, if we look at mortality, this is Canadian data looking at mortality risk by race, sort of racialized populations, as well as, sorry, I'm having a hard time seeing here, as well as by income levels. And what you see is, we had huge differences in terms of mortality risk based on essentially demographic and income level. Similarly, looking at the impact of interventions, what we saw was that if you break out the population by their income quartile or quintile, or decile, sorry, the bottom sort of earners versus the top earners, in terms of the impact of the lockdowns on the hours that they were working, was this huge gradient. So essentially, those who were earning the least were most impacted in terms of the amount of hours they were working compared to those in the highest decile who were able to, for instance, transition to working from home. An example where this information was leveraged to try to essentially adjust for these inequities was something that happened in Ontario when it became clear that residents of higher COVID-19 risk neighborhoods were least likely to get vaccinated. And so some modeling work was done, led by Sharmista Mishra at U of T, as well as others at the Ontario Science Table, to show that if we were to actually switch the strategy so that we focused on getting vaccinations in people living in those higher risk neighborhoods, we could actually have an impact population-wide in terms of reducing the number of infections. And that was a model that actually, I think, very successfully captured why, changing prioritization for vaccinations in this particular context was important, and it was a policy change that happened. So I think that was, a success story in terms of looking at the data, modeling it out, and showing that, there was population benefit to switching strategies. Model time horizon is, I think, an interesting one. So if you reflect back to the spring of 2020, when we were all learning about flattening the curve and how that was going to, help or prevent our healthcare system from being overwhelmed and reduce population mortality, one of the things that wasn't ever really talked about was this x-axis in terms of time. Like, how long were we actually talking about when we flattened the curve? And I think that was, from my perspective, a communication failure. Because, when we first had lockdowns, people were thinking, okay, we're going to flatten the curve for 2 weeks, and then we're going back to life as normal. And, that obviously wasn't the truth. And it wasn't something that, from a modeling perspective, I think we knew that. Maybe from a sort of communications perspective for politicians, maybe they didn't know that, and maybe that was a failure on our part. Maybe that was a failure sort of higher up in terms of not wanting to scare people by saying that, we're actually talking about a pretty severe and prolonged public health emergency. But again, I think that time horizon was, there sort of that lack of time scale was really important. And that was something that, in hindsight, I think we should have been better about communicating. So when it comes to choosing the time horizon for a model, the advice is to choose the time horizon of the model should be long enough to capture relevant differences in outcomes across strategies. So there's no clear answer in terms of what is the appropriate time horizon to consider. What I've shown here is an example of some modeling that we did early on in the pandemic, where we were looking at applying different potential public health interventions at the population level for different periods of time. So for 1 month, 3 months, 6 months, 12 months, and 18 months. So the model was run for 2 years in total. And essentially what we saw was that you really only started to see differences in terms, or sort of significant differences over this 2-year time horizon, when you started having interventions in place for a relatively long period of time. And again, I don't think, as modelers, this was necessarily, groundbreaking, but I think it was an important piece of information or an important thing to consider as we were sort of entering into this pandemic period. And this is just an example of, once we realize that we're talking about, months and months and months of interventions, we started thinking about, well, what is the impact of potentially turning interventions on and off? So, you sort of ramp up physical distancing, or, at this time we were sort of more focused on physical distancing and improving our ability to find cases. But, sort of recognizing that, you can't go 6 months, 12 months, 18 months with a population in lockdown. And so, what are the sort of other interventions that we might consider, or approaches that we might consider, such as turning them on and off when, dependent on what the epidemic dynamics look like. And again, that's something that, you wouldn't necessarily have seen if you only ran the model out for a month. One of the challenges with doing these longer time horizons is that they're not necessarily useful for precise planning. And so, this model that we presented here was at the very beginning of the pandemic. We had no idea that there was going to be emergence of variants. We didn't assume that, or we assumed that there wouldn't be repeat infections. We didn't account for, pandemic fatigue and the fact that population behavior was going to change over time. But, nonetheless, I think it did at least provide an initial overview of possible epidemic trajectories. One of the challenges with using shorter time horizons, which I think are more appropriate when you're trying to do forecasting, is that they may result in delayed action. So this is an example from David Earn's group, the group at McMaster, that did a lot of the forecasting for Ontario, where they were looking at trying to anticipate what was going to happen in Ontario. This was back in the winter of 2020, 2021. What was happening was that we had this very sort of reassuring looking epidemic curve where cases were going down. And there was a push in the province to open up the province, so to remove restrictions that were in place. The forecast was, if you were to just sort of look at that epidemic curve and draw a line, you might say, well, it's going to continue to go down. The forecast showed, well, actually, no, this is not going to end well. Once you lift those restrictions, we're going to have a pretty significant resurgence. And so the dots here are the data, and then the line is the epidemic forecast. So they predicted quite well what was going to happen. But again, that time horizon was important. So they were able to look a little bit further into the future versus this very short term, look 2 weeks ahead and make your policy based on that, which I think was, the preference of the government, for instance. In terms of the interventions that we model, the choice of interventions is something that I think is again difficult. Reflecting back to the beginning of the pandemic, we had identified this suite of potential interventions, and those have changed over time as we've learned more. And so, in the face of emerging evidence or improved understanding of the system that we're modeling or human behavior, as well as potential shifting of epidemic dynamics, we may change our interventions that we would consider possibly using to control spread. An example of that would be closing playgrounds. So that happened very early in the pandemic and was something that may have made sense at the time when we didn't really understand how transmission was happening, but became unpalatable once we understood that outdoor was reduced risk for transmission compared to indoors. Similarly, border closures and travel restrictions have been a source of a lot of controversy and debate. And again, the time at which those sorts of measures may or may not be appropriate will shift as the epidemic shifts. And so it's not like there's a single right answer here. It really is sort of contextual. And I think the key here is that we do need to be willing to incorporate new information and also admit errors that we may have made. The other, I think, potential driver of what we would include in a model relates to either political pressure and or expert opinion. So certain interventions may be deemed unacceptable or unpalatable or unfeasible. And that acceptability may actually change over time as well. So I think masking is a really good example of this. So at the top here, what I'm showing is something that was posted on the Government of Ontario website in June of 2020, which says face coverings will not protect you from getting COVID-19. There was a very long list of reasons why we shouldn't adopt masking in the pandemic. Insufficient evidence of effectiveness could lead to a shortage of PPE for healthcare workers. There was concern that people would engage in risk compensation. So essentially by wearing a mask, they would engage in other risky behaviors, so they would not continue to do other productive health measures. Something that's floated a lot of times when it comes to public health interventions, not just during COVID. Paternalism, so people won't use masks properly, people won't know how to dispose of them properly. There were concerns about kids picking up masks, dirty masks from the ground and getting COVID that way. And then there were also this floating of potential harm. So discomfort, you wouldn't be able to communicate as well. It's important that, not being able to see people's mouths will impede, accessibility. There were a lot of concerns, and the general sense was that those potential harms are greater than the potential benefits. So this is some modeling work that I helped do. Again, this was in, I guess, the spring of 2020, looking at sort of accepting all of those arguments. Say we don't have great evidence on the effectiveness of masks. People may not use them well. Does that how much does that matter? And what we showed is that, even if masks aren't perfect, they're not the perfect intervention, people may not accept them, only a proportion of the population will use them, they still have the potential to reduce the reproduction number below 1, particularly when used along with other public health measures. So, if we're relying on masks alone, maybe, they're not going to be a silver bullet, but they are an additional layer of protection. And so this argument that they're not perfect shouldn't have impeded us in terms of our willingness to adopt mask use. And I guess the final piece of sort of building a model that I wanted to talk about and how that might impact the sorts of conclusions that we draw from them relates to the outcome measure. So the example that I wanted to talk about here was vaccination. So early on, when we had limited vaccine supply, we needed to prioritize who got vaccinated first. And so I think in most countries, we landed on, the prioritization was to really try to reduce number of COVID-19 deaths, as well as reduce pressure on the healthcare system. And that, that outcome would result in us prioritizing older age groups and others at increased risk of severe outcomes. Another potential outcome that we may have focused on could have been reopening of society. And in that case, you would focus on certain occupational groups to allow the, restaurants and places where you have people working in essential jobs where they have high rates of contact with other individuals. We might have chosen that as our outcome. We might have focused on vaccinating a different segment of the population. And in reality, we had a bit of a hybrid approach where we were vaccinating those at increased risk of severe outcomes, and also healthcare workers and other essential workers. I think one of the things that I've been thinking about, and I don't really know how this will impact sort of our future decision making, is around, as the relationship between cases and severe outcomes has changed with vaccination. So as we have a lot of people getting infected who are potentially vaccinated and then are at reduced risk of having severe outcomes, we've had less of a focus on prevention of infections. So we're really focused on hospitalized cases and mortality. But we're also starting to learn a lot more about the longer term consequences of infection. So long COVID or post-COVID condition. And I do wonder how, as we stop tracking these infections and as we stop really being so worried about them, how that may have longer term consequences in terms of population level disability due to post-COVID condition. So this is an analysis that was done, it was published this fall, looking at 136 prospective COVID-19 modeling studies that were published in the United States. So this is up until August of last year. And again, I just wanted to focus in terms of what I was just talking about, in terms of how people have chosen to model COVID. And what you see here is, if you're looking at the data that are going into these models, what's shown up here is cases and deaths. Most models are using those as key inputs, but very few models are using demographic information, and some of these other aspects that may further refine who's at risk of disease, and sort of as a result, we may be losing information in terms of understanding the impacts of different policy models that we're building. And similarly, when you look at the outcomes, again, really focused on deaths and cases. So again, I guess my pitch to you is to keep in mind the fact that building and analyzing a model is not an objective process. There are choices that are made in terms of what we decide to include and what we choose to exclude. We have to make judgments, and I'm not saying that that's a bad thing. I mean, obviously we're trying to build simplified representations of the world around us, and we can't include all of that complexity. And I think obviously that's fine and it's appropriate, but I think it's important that we sort of reflect on that and think about what we're excluding, and to document that, be clear about the choices that are being made and the reasons for those choices. And I think there are two reasons to do this. One is it allows us to document data and knowledge gaps. So if there are things that we wanted to include in our model that we can't because we don't have the data, that's again an important thing to recognize and to document, so that next time we can actually improve what it is we're collecting when we're collecting data and when we're building data systems. And I think it also increases trust in the modeling process. So when you're presenting and you're able to say, we did think about this, and we, opted to focus on this instead because of, discussions with stakeholders or because of data limitations. Again, I think that can help with communication. So I guess I wanted to shift gears for the sort of rest of the talk to talk more about communication of results of modeling studies. So I would say before COVID, I had a very different perspective in terms of how we communicate. I would never have spoken to a reporter. It would like stress me out. It still stresses me out to think about now. But I was comfortable within the academic world and talking to other academics and, criticizing my models and taking them apart and whatnot. Like that for me was a fine process. But the idea of, trying to communicate our findings to the broader world was something that, scared me, to be perfectly honest. People might not understand, or I might describe things in a way that was unclear or inappropriate or got taken or misinterpreted. I would say, though, it became very clear early on that models were actually a really useful tool for explaining why we were doing the things that we were doing. This is an example of something that I had the chance to be involved with, again, very early on in the pandemic. So this, I think, was March of 2020, where we helped some reporters at the New York Times explain essentially why we were doing these interventions. At the time, we were calling them social distancing. I guess now we would call it physical distancing. But why only doing that for 14 days really wasn't going to have a huge impact on the population. And the reality is that we were going to be having to have these interventions in place, assuming that we didn't have vaccines or we didn't have other interventions at the time, for a longer period of time. And the process of working with these reporters and trying to convey the information in a way that was accessible was a really, for me at least, eye-opening experience. Something that I also explored a fair bit throughout the pandemic was the use of interactive tools. So to try to make models more accessible, not only to decision makers, but also the public. And so essentially, what I did with several of our models was to build shiny apps. So little apps where someone could go in and essentially change some of the model parameters and put in what they thought was their value, their sort of understanding of how the system might work, and see how that changes the findings of the model. And so this is an example of something that I did with this was actually not my model. It was a model that was built by Alyssa Belinsky and Megan Fitzpatrick in the United States, but they were looking at how community transmission affected COVID-19 risk in schools. And so I worked with them to build an app so that people could essentially use this, this was back in the fall of 2020, could use this tool to enter in their information for their particular community and get a sense of what the risk was of there being a case of COVID introduced into their school setting. Oh, my emojis didn't work. So you'll have to imagine, if you can translate these, I'll try to translate them to you. So I think one of the other sort of important things that I've experienced through this pandemic is that modeling studies can evoke really strong reactions. And I think this particularly occurs when there is a clash between pre-existing mental models or pre-existing beliefs and the model results. And so what I've tried to show here is that we have sort of two dimensions. One is the user, so the end user, the consumer of the model. Do the model objectives align with their objective? And then the other dimension I have here is the model identified optimal course of action aligned with the end user's desired course of action? And I'm going to walk you through this in terms of a couple of examples. But essentially what I'm trying to show here is that in this dimension, when we both, the model and the end user, have similar objectives and they both sort of are aligned in terms of the desire, the course of action, the two reactions that I've experienced are happiness and also sort of indifference. And I'll talk about that more later. Not aligned, but so you have different objectives, but the desired course of action is aligned, then I would say this is kind of meh. It's fine because we're still going to do the thing that you wanted us to do. You may not necessarily feel that the model added anything to your decision. Over here, I had a couple of emojis, one of which is supposed to be like the sort of celebratory emoji guy or emoji person. The other one is the sort of puzzled emoji person, and then the third one is the sort of angry emoji person. So this is when you both the end user and the model have the same objective, but the recommended course of action based on the model results isn't aligned with that person's thinking in terms of what we should do. And then this one here is the red-faced cursing emoji. And we'll talk a little bit about that in a moment. So as I said, I think there can be a strong reaction to models, and this is probably my best example of that, which is a paper that we published this past spring, looking at the impact of population mixing between unvaccinated and vaccinated population groups. And really the purpose of this model, and it was a very simple model, so it was essentially a model with two different population groups who mix between each other. The population groups were vaccinated and unvaccinated, and we showed that when the unvaccinated group is interacting with the vaccinated group, they introduce risk amongst the vaccinated group. And we also were able to show that the degree to which people of these different population groups interact with each other can infect disease dynamics. And again, I don't think as modelers this is particularly groundbreaking, but the idea was really to try to explain the rationale behind policies to increase vaccine uptake. So the reason that we had vaccine mandates and vaccine passports in place. And the responses from the peer reviewers were negative in the sense that they said, these results are obvious and they're not novel. If you're a modeler, you would say this is a simple model, like what's the point? So what? This is how things work when you have two populations that mix, and there's nothing new there. Following publication, so despite the fact that the results were obviously not novel, it did get published. And after publication, we received a lot of criticism. And what I'm showing here are the sort of fit for public consumption feedback that we received, which is, we were using flawed inputs to vilify a minority, potential to foster social division and misplaced anger and blame. There were calls for my co-author to be fired from the university and to be investigated for academic fraud. It was like, to be perfectly honest, it was a pretty the response to this was not something that I anticipated, I guess I would say. I got a lot of emails. So the reason why I would sort of argue we had these very polar opposite reactions. So, on the one side, for people who were reviewing this, who, worked in public health, who, objective was, to use vaccines to protect the health of the population, the model identified course of action, which was, to get more people vaccinated and to, potentially use mandates or passports to try and, improve to basically reduce the transmission in the population, reduce the number of severe outcomes in the population. They were aligned. And so I think their reaction was kind of meh, like, yeah, this is obvious. And then at the other extreme, we had people who were, very much against vaccine mandates, very much against vaccine passports or anything that restricted the ability of unvaccinated people to participate in, to go to restaurants, for instance. And again, the policy that we were modeling, which was, mandates and passports, was not at all aligned with them. And so I think, the reaction was essentially, this model is gamed, or this model is not helpful, and it's wrong and it's fraudulent, et cetera. And I guess the thing that I would say is, I don't know. I don't think from a communications perspective that there's much, at least from my perspective, I wasn't able to come up with a solution to this. I think when you have this misalignment in these multiple dimensions, I don't really know how you reconcile that, or how I don't know that there's a better way to communicate that would prevent that from happening. And I'd be happy, if we have time, sort of once I'm done, to if others have thoughts on this, I'd love to hear other people's reflections. I guess the thing that was kind of interesting to me is that the results were actually not that dissimilar from the masking paper that I talked to you about earlier, in terms of mixing and how mixing between different population matters. I think the difference was the political atmosphere. So that first masking paper was in the spring of 2020, whereas this vaccination paper was in the spring of 2022, at which point there was a lot of pushback in general against any sort of pandemic response measures, particularly vaccination. So I just wanted to give one other example, again, sort of looking at this other box here, which is where you have aligned objectives, but the model identified optimal course of action differs from what the end user thinks may be the optimal course of action. And the example I have here is some modeling that we did in the winter of 2020, 2021, so when vaccines first became available. And the reason that we built this model was that when vaccines first became available in December of 2020, we had very limited supply. And at the time, the recommendation was that you give first dose followed by second dose 3 weeks later. And this was based on the original RCTs. And what was happening in some regions, this was really sort of triggered by what was happening in the US, was that vaccine doses were being held back in storage to ensure that when people returned in 3 weeks for their second dose, that there would be enough vaccine supply available for them. And so you essentially had this supply of vaccine and some was being held back. And this was really sort of an optimization problem, less than like a sort of infectious disease modeling problem. But we used a model to look at a strategy of using all of the available doses immediately versus holding back some of the supply for second doses. And what we showed was that getting more doses in arms resulted in more rapid improvement in population health outcomes, even if supply interruptions resulted in a potential need to extend the interval for first and second doses. So essentially the take home from this model was like, you have all of these vaccines, get first doses in arms as quickly as you can, it's going to have benefit. And if worst case scenario happens, supply is disrupted, it's not going to have, at the population level, it's not going to have a huge impact. And so we had the chance to share these results, both within Canada as well as internationally. And the responses were pretty mixed. I think, at the time, the sort of accepted wisdom was, we really need to focus on getting these 2 doses in arms at this 3-week interval. That's what the vaccine manufacturer is recommending. And so, some people looked at this and said, yeah, that makes sense. It makes more sense to just get as many people vaccinated with their first doses as fast as we can. But there was a fair amount of negative response to this, in the sense that, people were saying, that this is not what the RCT is showing. This is, deviating from what, public health is recommending. This potential of a supply disruption is, sort of too risky for us to really, focus on getting these first doses in arms. And I think what my takeaway from this experience was that, we needed to present a lot of scenario analyses. So we looked at, all of these concerns. What if, first dose is far less effective than the protection you receive after that second dose? What if, after 6 weeks, the vaccine supply completely dries up? What if people end up only getting 1 dose? And I think the other thing that we also focused on emphasizing was that we weren't suggesting use of a single dose. We were saying, it's important to get those 2 doses. The vaccine trials looked at 3 weeks, but also people within that trial received their second vaccine up to 6 weeks after their first dose. And, they still had protection against infection. And so I think in this case, it was a matter of sort of addressing people's concerns and trying to include those in the model to allow them to essentially say or recognize that, if this wasn't aligned with their preconception of, the best way to use the vaccine doses that we had, it was still a valid approach. And I guess the final thing I wanted to talk about was uncertainty. So, as modelers, we're very comfortable, I think, with uncertainty. We do all of our sensitivity analyses and uncertainty analyses, and we explore different scenarios. But typically when you're presenting results to decision makers, they want to know that bottom line. What do we do? What does the model say we should do? And often the answer we'll get from models is it depends. And so, if you present a model with very large uncertainty intervals, you may get, the reaction, well, this is not helpful. And yeah, maybe it's not helpful, but it's the reality. It reflects our current state of knowledge. And I think, from, as scientists, I think it's important that, if there is uncertainty or there's no clear optimal policy option, that we should be able to present that. And again, recognizing that, from a decision maker's perspective may not be useful, but I don't think that we should sort of force our models to have certainty where they don't have certainty. And so what I have here is an example of some modeling that we did again, I guess this would have been the summer of 2020, when we were trying to sort of get a sense of how much testing capacity we would need in the province of Ontario. So, testing was starting to scale up. We were trying to understand, based on the potential epidemic trajectory in the fall, like how many tests realistically would we need to do per day? And the answer was incredibly unsatisfying. It was basically, it entirely depends on what else is going on in the population. You know, if we have continued public health measures in place, then you probably won't need a ton of testing. If you take them away, you're going to need a lot of tests. And so, you know, it was kind of like a bit of a circular modeling exercise where we needed to have a sense of, you know, what was going to happen in the future to be able to provide anything meaningful. And I think, you know, one of the things that I've also taken away from this experience is the importance of focusing on important uncertainty versus unimportant uncertainty. So the example I have here is some modeling that was done in February 2020. So over the course of a week, Iran reported 43 cases and 8 deaths in their population. And at that same time interval, there were 3 internationally exported cases. And so we have some people here from Blue Dot who are going to talk. I think one of them will be on the career panel this afternoon. But we were able to work with them, including Alex Watts, who was here this morning, to estimate the, you know, based on air travel data, you know, what's the chance of an exported case showing up, for instance, in Canada, when there's only 43 reported cases in the entire country. And so we estimated, you know, based on these cases that we were seeing exported elsewhere in the world, that there were around 18,000 actual cases in Iran over about a month and a half time period before we started seeing those reported cases, in order to be able to see those exported cases. And we had wide uncertainty intervals around that. So we're talking, you know, somewhere between 4,000 to more than 50,000. But, you know, I think in this case, you know, the important thing was that we weren't talking about 43 cases. We were talking about a substantially larger epidemic in the country than what was being reported. And that was what was of concern. It wasn't, you know, the precise number. It was just the fact that, you know, we have a lot of cases happening, we have a lot of transmission, and it's not being reported. And this work was validated, unfortunately, shortly thereafter, when, you know, we started seeing satellite imagery of mass burial sites in the country. So they did, in fact, or were experiencing a very large epidemic wave at the time. So just to summarize, infectious disease models can't capture all of the complexities and dimensions associated with the pandemic, because we are dealing with this wicked problem. And, you know, there's so many interconnections and important variables that models, at this point at least, maybe, you know, next pandemic will be in a different situation where we can capture all of these broader health and societal effects. But at this point, we can't. And so there's de facto going to be choices that are made and simplifying assumptions that need to be made. And I think models are still useful for helping us make decisions under uncertainty. But we need to keep in mind the fact that this isn't an objective process, and transparency about data assumptions and value judgments can help build trust. And I think that building of trust and that ability to really communicate well what it is we're doing and what those limitations are can potentially help in terms of overcoming some of the challenges associated with communicating the findings of modeling studies. And I'll just finish by acknowledging the people listed on the slide who contributed to the work that I talked about today, and very happy to answer questions that you may have.